Welcome to the Therapeutic Management of IBD, the Paradigm Shift to Personalized Care Symposium. This section of the webcast is titled IBD Risk and Benefits, the Balancing Act, presented by Maureen Kelly. Once you have completed this activity, you will be able to evaluate the risks and benefits of current and emerging therapies for IBD. I hope you enjoy the presentation.
Okay. I am the third and last leg, so I will not be long-winded. But I just wanted to start by saying how important it is to address risks and benefits with our patients. As a pediatric nurse practitioner, you can imagine it's more difficult when you're dealing with an adult who's making decisions for themselves. That's hard enough, thinking about all the risks involved with some of the therapies that we use. When you're talking about a pediatric patient and you're making that decision for your child or your young adult, it is much more difficult. All right, so I wanted to start with this slide, which is similar to one that Michelle had. And really what it looks at is 9 goals that we have for IBD management. And you can see all but 2 of the goals are bolded. And it's not because the other ones are not important, but it's because those are not directly impacted by our therapies unless you're thinking about enteral therapy. We really want to start by treating inflammation, and it's all about mucosal healing. And if we've treated the inflammation and we have mucosal healing, then a lot of the other goals will take care of themselves. If we have a well patient, they will feel good and it'll improve their quality of life. So really, this is all about a balancing act. Balancing the risks of some of these medications that we use with the benefits, the risks of not treating the disease. If you think about how people like to obtain their information, if they're not getting it from their medical team, how do they get it? They get it online, right? So we know they do that. And we can't do anything about that, but we can educate them as to how to get that information online. i.e., if they're going to use websites, make sure they're using reputable websites. The Crohn's and Colitis Foundation has accurate information. That's a good place to start. If they're looking up cancer risk, have them look up IBD in cancer risk. Look up the IBD and drug instead of IBD and cancer, because then they'll get more accurate information. It's really, really important to help them learn how to educate themselves, because we can't do all the education that they need. So we know when we think about these medications, one of the biggest concerns people have is developing infection and developing cancer. And so we know that there's concern about some of the medications causing cancer, but we also have to explain to our patients that continuous inflammation over a long period of time is going to cause cancer. So we have to weigh that small risk of cancer from the medications with the larger risk of untreated disease over a long period of time. As a pediatric person, improving growth and development is extremely important. You might say, well, we shouldn't use some of these stronger drugs in the pediatric patient. But if you have a pre-adolescent or adolescent patient who is not growing as they should, they're going to need that therapy now, not 5 years from now when it's too late for them to grow. I have a patient now who's 14 years old. She's 4 feet 7 inches tall. She came to us when she was 12. She had already started her period, so that meant she hardly had any growth left. Her parents are taller than average, so she lost a foot of her height from not being diagnosed with Crohn's disease at the proper age. It's a military family. A lot of our families in North Carolina are military. They move all around. Nobody tracked that child's growth chart. It's very, very sad. Risk, again, known side effects, known reactions, unknown reactions. trying to avoid surgery and trying to ultimately improve quality of life. If you can't get out of bed in the morning and can't go to school and can't go to work, then why worry about what's going to happen 20 or 30 years down the road? Risks of untreated disease. When we talk about risks of therapy, we have to discuss risk of untreated disease, because if we don't treat, they have worsening symptoms, worsening flares, increased risk of penetrating and/or stricturing disease. It increases hospitalization. They may need to have surgery. They lose time from school and work, and as I said before, increased cancer possibilities. So you've seen variations on this from Laurel and Michelle. What I want to say is that traditionally the approach was the step-up approach, but really now we're looking more at the top-down approach, especially for patients that have moderate to severe disease. What we lack at this point is good criteria for how to decide who gets that disease, who gets that higher therapy from the get-go based on their disease. So what I want to do in the next 3 slides is just briefly talk about side effects. And I'm not going to go through every one of these, but I think what we have to think about is we try to decrease the use of steroids. Steroids traditionally were a mainstay of therapy. Now we use them to induce remission, but we should be rapidly trying to get our patients off of them, partly because of all the side effects that are associated with it. Steroids are not good for long-term maintenance. You can see there's lots of side effects listed here. At some point, even if we've not weaned the patient off of the steroids, they may decide to stop the steroids probably about half the time due to one or more of these side effects. Side effects of methotrexate, probably about 10% of the population gets nausea, vomiting, and diarrhea. There are things we can do about that. We can give them daily folic acid. We can give them antiemetics to help with that. But really beyond that, I mean, that certainly is a reason why sometimes patients stop the medication, but there's certainly other significant problems in terms of myelosuppression, infection. For female patients, teratogenicity is a huge concern. So this next slide looks at side effects of 6-MP and azathioprine, and I'm not trying to focus more on 6-MP or azathioprine. What I'm trying to do with this slide is to show you how there are several side effects of 6-MP or azathioprine, but most of them occur 2 to 5% of the time. The biggest concern people have now about azathioprine or 6-MP is non-Hodgkin's lymphoma. And so what's important to note here is that even though there is a risk, it's a very, very small risk. The risk is 4 in 10,000. The risk for somebody who is not on a modulator, not on an immunomodulator, and not on biologic therapy is 2 in 10,000. Okay, so very small, but twice the risk of the average person. So therapeutic monitoring, I'm not going to really talk much about this because Michelle discussed it, but making sure that every single person has a TPMT done prior to thiopurine use. Absolutely essential. And that starting dose is based on that TPMT. Monitor that 6TG initially, and then periodically throughout, particularly if the patient is having a flare or significant disease. Continually monitoring CBC and LFTs, and then chest x-ray if they've got pulmonary symptoms, and absolutely essential for contraception and counseling. We require our patients to be on 2 forms of birth control. And we try really hard not to put the older adolescent females on methotrexate. So predictors of aggressive disease, there's a few different prognostic markers for this. Michelle had a similar slide. If you think about young age at diagnosis. If you're a pediatric person like me, I don't see anybody over the age of 22. So that's all of our patients. If we put all of our patients on biologics, that would be wrong, because some of them don't have aggressive disease. Many of them do, but not all of them do. Talked about cigarette smoking, need for steroids, extensive disease, penetrating or strict-string disease, including perianal disease, and then multiple genetic markers. So benefits of biologics: we know that biologics are helpful in terms of decreasing hospitalizations, surgeries, just general improvement in quality of life, and then being able to go to work or school and being a productive person. Side effects, this has been mentioned a bit already. I'm not going to talk too much about it, except for immunogenicity. It occurs with all the biologics. You can have infusion reactions. Again, getting back to non-Hodgkin's lymphoma, a lot of people worry about the biologics causing non-Hodgkin's lymphoma, but most of the cases actually were with azathioprine or 6-MP alone and not biologics. And I'll talk about that more in just a second with another slide. So how do we prepare our patients for biologic or immunosuppressive therapy? First of all, usually the sicker the patient is, the more they're willing to buy into the need for it. And that's a good thing, because we don't want to be giving drugs to patients that are higher level drugs than what they need, right? We want the mild to moderate patients to be able to use the lower level drugs and do well, but that's not always the case. We want to make sure anybody that's getting these immunosuppressive medications is not sick. Not as important, I shouldn't say not as important, but it's harder to do with the immunomodulators than it is for the biologics, because you're taking the immunomodulator if it's a thiopurine every day. For the biologics, you're coming in oftentimes for an infusion, and somebody can assess whether you've got an infection. But you certainly want to make sure you've got TB testing done beforehand. You want to make sure patients have updated vaccinations beforehand. You want to make sure nobody's getting live vaccines if they're on immunomodulators or biologics. Recently, they have come out with, you can get the varicella vaccine if you're on an immunomodulator or a lower dose of steroids, but you still can't get it if you're on a biologic. And then with natalizumab, you need to get assays for the antibody for JC virus, and then register in the TOUCH prescribing program. So what should we tell our patients? Well, all medications have adverse effects. Most serious effects, luckily, are rare. If we're good at helping them monitor for infection, and we're also monitoring for infection, and we're ensuring that they have vaccinations, that helps. Need to help them understand that they can't just come and get their anti-TNF drug or administer their anti-TNF drug when they don't feel well, because then they will be more likely to develop antibodies. Most of the time, the benefits are going to outweigh the risks. So clear communication is really important to patients. Do it in a way that they can understand. Realize that they may have trouble converting 1% to 10 in 1,000, 1 in 1,000 to 0.1%. Helpful to put numbers in perspective. So the chance of dying in a car accident, the chance of dying from heart disease, the chance of a serious side effect of IBD medication is about 6 in 10,000. Very small. Use absolute rates of risk instead of relative rates of risk. If somebody tells you you have a 2-fold chance of getting cancer from X drug, or you have a 3-fold chance of getting cancer from X drug, that's going to be scary, and that's considered relative risk. You always want to use absolute risk. So the average person at baseline has a 2 in 10,000 chance of getting non-Hodgkin's lymphoma. On an immunomodulator, that doubles to 4 in 10,000. You add an anti-TNF into that, and it goes to 6 in 10,000. What we don't know is what is the risk of getting hepatosplenic T-cell lymphoma, which is a subset of non-Hodgkin's lymphoma and a deadly disease. There's a very, very small number of patients worldwide who have gotten that, and we just don't know what the frequency is. We do know it occurs more in young males. The average age is something like 23. But again, it's a real risk, but very, very small. One way to help explain things to patients is a risk palette. So this just shows you the risk of developing non-Hodgkin's lymphoma in a 20-year-old male who's on anti-TNF plus immunomodulator therapy, visually seeing how small the risk is. Tips for clear communication: use absolute risks, don't use decimals, use a common denominator, use visual aids like the risk palette, compare it to other life risks like dying from heart disease, and then give individualized estimates to help improve retention. So lastly, health maintenance is absolutely crucial for any of these patients who are on these medications. We need to teach them how to manage their stress, how to get a good amount of sleep, how to eat a nutritionally balanced diet. All these things can help prevent flares in addition to the proper medication. Need to make sure they're vaccinated, including an annual flu vaccine. They need to come for regular blood work, regular colonoscopies. Laurel already talked about avoiding tobacco and NSAIDs. Yearly eye exams, making sure they have dentist appointments, getting a bone density scan to screen for osteoporosis, adequate calcium and vitamin D in their diet. If they've been on steroids or tacrolimus, they're going to be more apt to develop hypertension, so blood pressure screening is important. And it was mentioned earlier, depression screening. About a third of patients with IBD have depression, so we not only need to know how to screen them, but we need to be able to get them effective treatment. And then lastly, age-appropriate cancer screening, like colonoscopies, pap smears, and skin screening, because thiopurines do cause, in very small percentages, non-melanoma skin cancers, which of course is treatable. So lastly, we don't know the exact risk of some of these therapies, but we do know that they've been around long enough that we know that that risk is probably pretty small. If you need the medicines and you can't get out of the bed in the morning, then the benefit is going to outweigh the risk. It improves quality of life, helping the patients understand the trade-offs. What is the risk of not treating versus treating? If that risk of not treating is much higher, which in many cases it is, then treating with some of these small cases of side effects, then you can help them make that decision. There are some patients who will never be able to do it. They're just too afraid, but we have to give them the information to be able to help them to do that. And that leads me to my last bullet point, which is improved communication with our patients. If we don't give them this data, they can't make the correct decision. Thank you.